not really based on good data. It's just based on my giving them some idea. Here's the long and short of it. If a patient got BCG recently, 3 months ago, 6 months ago, or within the last year, their chances of responding to a second cycle of BCG is low, less than 20%, probably less than 10%. If a patient got BCG 2 years ago and they have had, they went for 2 years without any cancer and then tumor came back, then their chances of responding to the second BCG round is high, greater than 20%. They did well with BCG. It's just that they had been taken off of it, and so they had this interval. So there's this whole thing about early failure or late failure, and those really dictate who's going to respond to the second cycle.
Okay. Thank you. That makes a lot of sense. We want to move on to the information we sent you around the product X concept, labeled TPP, and then there's another slide that shows just sort of a flow of how it would be used. And I'll talk a little bit about the concept and make sure that it's clear to you, and then we'll talk about your reaction. So basically, the idea is it's photoimmunotherapy, so the patient isn't injected with a conjugated antibody, which will bind to the tumorous cells and make them photosensitive, and then later a near infrared light is shined within the bladder, and the light then affects the sensitized cells and disrupts the cell membrane, causing death. So that's the overall concept. I guess on the TPP slide, again, it's for the high grade unresponsive. We are assuming that we will do a comparator trial, not a placebo trial, and the comparator might be one of the newer products that's in development, like Instilogin, I think is the furthest one along in phase 3. It could be Vicinium. I guess we could do against Valrubicin if nothing actually else is approved at that point. The complete response rate would be about 50% at 12 months with the TAT1 and 35% with the CIS. And we don't expect, at least not right now, any severe adverse reactions. Where it gets tricky is the details, I guess, that the injection would be some hours before you go in with the scope. It could be between 2 to 24 hours, and right now our best guess is 6 hours beforehand. You would have to inject the compound, and then the scope emitting the light would have to be in the bladder for 30 minutes. And that would be sort of the initial therapy, and then if successful, the idea would be to, much like maintenance therapy, just repeat that every 3 months. So overall, I guess I should ask, do you have any questions about the concept or how it fits into?
Well, yeah. So, I mean, I'd like to know more about the science here and what particular antigen is this antibody binding to? Why do we think it's going to be found on all bladder tumors? I wish I had an antibody that could detect all bladder tumors. So that's part of my concern. I'm not. It doesn't necessarily mean this won't work, because this could be working by a bystander effect. And it's not really specific for the tumor, but some bystander. So sometimes we find things that work remarkably, even though the science is not all straightforward. So I'm not saying that means it's not going to work, but I'm really curious as to what antibody is specific to bladder tumors, because as a scientist that deals with bladder tumors all the time, I can tell you that there is